Hi, my name is Simone Tank, and thank you so much for joining me today in between COVID and Comcast. And I'm almost positive I have compassion fatigue. I really, really appreciate you rescheduling your time. I'm going to shorten up the presentation today and probably do like 33, 35 minutes. If we have time for question and answer before then, we'll go ahead and do that. Otherwise, you can just shoot me an email. And I'm going to record this presentation this time in case any of us drop off. If I drop off, at least it's going to reload. So let's get started. I'm going to share my screen with you real quickly. And as this is near and dear to my heart, we're going to kind of toss it up a little bit, and we are going to work with, are they actually in denial? And I will tell you what, this may be something, if you don't eye roll or at least shake your head a couple of times, then I'm doing my job wrong and I have a ton of student loans to pay back. So I got to create a little bit of discrepancy. So are they actually in denial? Let's see here. All right, our topics of discussion besides accommodate relief is we're going to look at the clinical versus moral definitions of denial. We're going to review survey assessments on what is your definition of denial. I am going to read out their responses just to acknowledge, because I'll tell you what, people got raw and deep, and I did the survey over across the board. Some people I don't know, some people I do know. It was pretty exciting for me to see those results. We're going to review the MSPs at a glance. We have a ton of mutual support programs for counselors, for addicts and clients and their families, other practitioners. I'm introducing emotional recovery as a means of recovery enhancement. Recovery enhancement was something that my former teacher, Dr. Timothy Burdick, had actually posted right towards the end of class. And we had to do something like this similar as far as a presentation saying what we learned about relapse prevention. And that's when he shared with us that, like, hey, what would it look like if we shifted out of this relapse prevention side? Because what we're doing is enhancing people's recovery. Which I completely bought into, right? Because I am all about emotional sobriety, and especially for clients and families and us. Like I said, a little bit of compassion fatigue during COVID, dropping off on Zoom, I mean, emotional recovery, when that gets challenged, everything gets challenging. So the feelings wheel and how it applies to dimension 3. I'm not sure if you've heard of the feelings wheel, or if you've seen the feelings wheel, or if you're, a family marriage therapist and you do this with kids. It's great though, very, very safe outlet. So we're going to talk about that, throw it into dimension 3. I've got a new little deal excited to show you. So I want us to kind of look at, what does it look like when we're asking these questions? We all know the ORS process, right? We all know the open-ended questions, elicit, provide, elicit. We do all of this. And then we try to give that affirmation, and bulk up that client's confidence. But we got to change up the affirmation to really match their language and their needs. And then we're going to wrap up. So let's get started. This is just going to be like, this is part of the survey, right? I mean, just want to showcase what we're working with here. So do you identify as BIPOC? We have 67%. We have 18 responses, right? I shot this out to about 30 people and grabbed the first 18. And so we got 66% say no, 33% said yes. It's great that we didn't have any unanswered. The identified gender, right? Half and half. Like, I did make it where it's a half and half split. And again, right now, to be able to have people to tell you like how they identify is huge, because some people are placed in positions they're not comfortable anymore. And that's something that we as counselors can help to change. What generation were you born in? We've got a third of them were in baby boomer, Gen X, 44%, Gen Y, 16%, and we did have some unanswered. Political party that you identify with most. I know that right now there's a lot of disruption and there's a lot of division and there's a lot of stereotyping and bigotry and you name it, we've got it. So I knew that it was a risk to ask this question. And a quarter of the people didn't answer or didn't prefer to answer, and that's totally okay. But I like seeing this little mix. So a third of the participants went blue, right? Democrat, liberal. 20%-ish went red, Republican. And then we've got like our third parties or people that typically identified one way or leaned into one way. However, there were a lot of other parties that they affiliate with, maybe on state and some federally. Then I wanted to know their professions, right? Because when I'm asking people what is the definition of denial, we clinicians and healthcare professionals, chiropractors, even our law enforcement, we are trained to do screenings and assessments and things like that. We're trained in some form of motivational interview skill. We're trained in some form of way to challenge somebody or to acknowledge what they've got going on. And especially on the counseling side, and even some nursing sides, it's sometimes difficult to set aside everything that we think we know when people are giving us these answers. And maybe we just feel like, okay, you're in denial, you're not acknowledging it, you're refusing to look at this. All right. So I wanted to know what that is. And we've got a third are in the healthcare and human social services directly, right? So a third of the participants, not including myself, are right there. This is what we do. And then we have enforcement agencies and armed services. And I put that in there as we are shifting into where does the social worker fit in a ride-along situation? Finance, business, and administration. That aspect is important for those leadership skills. Everybody knows motivational interviewing with Miller, right? And so let's see here. Sorry. Okay. And then we have our other unanswered. Maybe they were retired. Maybe they just kind of bypassed that. Maybe it wasn't any of my business what they did. Highest completed level of education. We do have, right? 15-20% of people are like, again, not your business. And that doesn't mean that there's no college. Maybe they just overlooked the question. I had a lot going on that day, right? 60% higher education. And then we've got 20% some college. Sorry, if I'm talking super fast, you're gonna get in there with me. You're gonna totally, within another couple of minutes, be able to track. So then this part is, do you currently have any children in your household, right? And I'm looking at that single guardianship. So, parent, grandmother, foster, adopted. And then the dual guardian or the multi-generational. So when we have 2 or more generations going on, or dual guardianship, sometimes that means that there's marriage, sometimes not. And then our no children or empty nester. And these were for participants that maybe didn't have family right now or didn't have a child right now, but would in the future, as well as people that their kids are done and grown and out. They're probably paying for college. And in contrast to this, as we are talking about denial, I wanted to look at, by the age of 18 or when people left home, did they live in this dual guardian or multi-generational household? Did they live in something that was society or culturally traditional? And about 40% said yes, 25% said no, and 33%, again, not my business. So moving into denial, and we're going to go off of the APA clinical definition. I'm going to check our time. And so the APA clinical definition of denial, because sometimes we do have that educational variety of client that does like to call us out on our terms. And I was that student, and I kind of still am. So denial, a defense mechanism in which unpleasant thoughts, feelings, wishes, or events are ignored or, and I'm not sure if you can see this highlighted, excluded from conscious awareness, right? It may take such forms as refusal to acknowledge the reality, refusal to acknowledge of a terminal illness and financial problem, an addiction, or a partner's infidelity. I don't know why that part needs to be in the APA, but it is. Denial is an unconscious process that functions to resolve emotional conflict or reduce anxiety. So, two parts of that unconscious process, right? We don't even know. It doesn't even come into our head. But it's used to resolve emotional conflict and reduce anxiety. So emotional conflict, obviously we know that there's something going on. So already on the APA side, how we're trained, we already have a little bit of conflict and challenging in our concepts, right? So we have you ever been told that you were in denial, right? Did you agree with them? So we have 10%, right? I have been told, right, that I was in denial. They explained it, I agreed with them. Over 40%, I've been told I was in denial, right? Whether they explained it or not, no agreement. 20%, I have never been told I was in denial. Now, us being in the professional and the counseling field and any kind of social worker, human services, I was actually surprised. Now, I couldn't find a study like this, hence why I needed to do it for myself. But I was surprised that 20% had never been told. It was a little bit relieving, right? So here are their responses to what is your definition of denial. Now, I want you to keep in mind the clinical definition that we just talked about, right? Freud came up with that part. And then I also want you to think about that 30% of these responses are coming directly from the counseling field. And I am going to read one by one. I want to acknowledge all of the people that helped me to get this together. So, to act like an event did not occur by ignoring it or refusing to talk about it. I define it as a defense mechanism people employ when they find it too difficult to introspect and recognize obvious faults or problems, usually referring to self, but sometimes external. When one not only maintains positions that are intellectually dishonest, but goes through mental gymnastics to constantly adhere to them. Not wanting to see things about ourselves that harm us or keep us from happiness or joy. Not being willing to take accountability for the things that cause self-harm, be it an outside influence. And this participant's definition actually started going into a lot of examples and this toxicity of addiction outside of drugs and alcohol, you know, but also sex and gambling, all of these things came up. Not able to accept the truth, right? Short, simple, to the point. The avoidance or unacceptance of something. Not even acknowledge there's a problem. To disagree with someone accusing you of something. Denial, I believe, is not believing the truth. The truth is not subjective. Now, I do want to say that I did not ask any of these people if they were in recovery, nor did I let any of these people know that this was going to be a presentation on relapse prevention, recovery enhancement, emotional sobriety, and challenging the word denial. Not even acknowledge there's a problem. To disagree with someone accusing you of something. Now, there's definitely a pattern, right? Everyone's kind of saying the same thing. Some people are going more or less, and some people are going out of this world on it, which, I agree. So intentional and or unintentional denying of an object or an idea. The inability to admit reality. Unsure, I usually hear resistive. I want to talk to this individual more because I love that. It's like we know what that resistance is, and we know that the but that we hear doesn't mean denial, that it does mean resistance. So I'm excited to talk with that participant more. When a person is guilty of something but can't admit it to themselves. Not wanting to focus on or believe something that's true. You might believe it if your actions are not aligned with it, and are not aligned with it could be said you are still in denial unless you are facing the truth of whatever it is. Being refused something, also denying the reality around yourself. I love it, right? Textbook definition of denial. Like, there's the question, what's your definition? And just boom, textbook definition. And so if we remember what that textbook definition is, we're working with unconscious awareness, we're working with refusal to acknowledge, we're working with the inability to, see anything, yet at the same time, we're going to utilize this as a defense mechanism to resolve our emotional conflict, to reduce our anxiety. Why? Why do we have such an array of answers? And like I said, we've got some participants are saying like, hey, this is the textbook definition of denial. That's what I'm going with. And other participants are talking, largely about all of the different effects. And these are coming from, like we saw, these are coming from people that were told, hey, I've been told I was in denial and I disagreed with them. That drops down even further into, were they given examples? Some of them were given examples as to why the person had said, I believe you're in denial, or maybe they came across a little bit more gruff, maybe they came across a little bit more graceful. But some of the participants, right, did say like, hey, this person explained, and guess what? I still didn't agree, because it didn't match their definition of denial. And as we saw another participant who shared with us, hey, truth is not subjective, like it is what it is. So why is it that we have so many of these definitions and responses coming up? Well, there are 6 theories of denial, broadly, of denial. And we've got our moral defect, so think about like the pick an A. I like to call it pick an A because there's so many. Our Alcoholics Anonymous, our Nar-Anon, our let's see, Cocaine Anonymous, Marijuana Anonymous, Narcotics Anonymous, right? Like pick an A. And these are our moral interventions, right? Our 12 steps. And we send people there all the time. But this is where it starts coming out of, this was a moral disease. So this is like an emotional conflict. And then we've got denial coming into there. Then we've got the interactional. And this is, our motivational interviewing. And with motivational interviewing, having such a success rate, whether that's on like the quick side, right? The MET, the motivational enhancement therapy, we're going to do 4 to 6 sessions. We're going to get you up and going. You probably have the resources that you need. Or this longer side of motivational interviewing that we typically see in outpatient settings, or preparing them in transitional. We then have the mental impairment, which, a lot of people that I have talked to don't necessarily know what confrontational therapy is. And I remember learning about, this theory, and it was just like a little bit at a time. And actually that is what confrontational therapy is, right? Like we have to do some things repetitive. We truly got to start back at the baby steps and the basics, right? Like, let's get some life skills. Let's get some job skills. Let's find some purpose, not just staying sober from drugs and alcohol, but what is it that we got to do to make us more comfortable that jail doesn't sound like an appealing idea? This is usually also found in long-term treatment plans, long-term inpatient facilities, residential, and or transitional housing. You see it in jail, right? Then we have the psychodynamic. We all know, who's to start for that. We've got Freud, and then we're extending into all of our therapeutic models, our CBT or DBT. Then we have the phenomenological. Now, this is something very closely related on that moral defect side and on that like science evidence-based side, which says our client needs to self-diagnose themselves, right? Like it's not necessarily about denial. It's the fact that they need more education. They need to know fully, without a doubt, for themselves, yes, I'm afflicted with something. Yes, I'm addicted to something. Yes, I'm putting myself at risk to not be the better intentional self I know that I can be. So kind of sets aside the clinical diagnosis. The last one is great, right? This has been elaborated over time. This has grown and mushroomed over time. And this is the stages of change. And this is where, they have predominantly removed the word denial from it. And we start calling it like the pre-contemplation side of it. And in pre-contemplation, it's not saying like, hey, I'm not this, or hey, I know I need to quit, but I don't want to. It's not about that. It's that maybe possibly in the future I will, or hey, I'm still going to show up and kind of hear what my counselor has to say. Whether I believe that person or not, something in me shifts and changes every time I talk to that person or I go to that group. There's not that expectation that you have to stop everything right now, change your life. It's going to be okay. So we've got the 6 theories of denial taking place. And when we're looking at 18 responses, right, and we're seeing that none of them quite match, we can start looking at this, is where they got that from, either from a counselor or a practitioner or, just a friend of the family or in a moral support, network. Where are they getting this information about what denial is? Are they getting like the one person suggested textbook definition? Are they seeing somebody in, the psychoanalytic side, or mental impairment? Is this person coming out of corrections, or are they in some kind of a long-term gain all of my skills and get prepared for that full autonomy on my own on the outside of walls? Are they doing the motivational interviewing? I mean, if you think about leadership, and this is where that profession of finance, mainly real estate too. I was in real estate for a long time on the accounting side. And we always had these leadership conferences. And my direct boss was a very, very motivational person and boss. Like, she always wanted me to achieve more because she believed in my excellence. And there were times where like I literally would have to sit down right next to her and start clicking the buttons, and she got me to the point of being asking for help from others. So there's definitely that part of me that she had read plenty of books. Moving along, here's where this, can become a problem is in our assessments and our screenings, especially for substance use professionals, for psychiatrists, for social workers, for our EMTs, for our nurses, for our law enforcement officers, right? When we're doing even a quick PHQ-9, you know, or whether it's like a full-blown DSM criteria check, you know, like let's check all of these boxes. In the back of our head, we are going to think about, is this person being honest with me in this moment? Can this person be honest with themselves in this moment? And how does that marry together? One of the problems and the challenges is that reflect back to the responses, that over 30% of those responses came from counselors or law enforcement, people in the healthcare field. And I will tell you what, it's not the long responses. And so that's where we have to beg to question ourselves is, how comfortable are we doing these, that we're not looking at this individual as an individual? How many assessments are we doing a day? How much telehealth do we got going on during a day? How much compassion fatigue are we in? And how many how many clients do we see, or potential clients do we see, that we truly are diagnosing them appropriately for them? Are we truly listening to everything that they are saying and how they're saying it? Are we doing the nonverbal cues? Are we listening to the tone of voice? Are we watching, them do this, are they getting loud? Are they animated like me? Are they not? And I do know that originally I was going to do the presentation with denial and deflection, with us having to crunch time today. And I'm almost worried that we may go a little bit over. I'll do a second presentation about deflection. And here's the fun fact, that's not even in the APA. Probably we as counselors should stop using that word. It is projection and it is traits of narcissism, but yeah, not for therapy. So when we look at just some of like the basic quick tests that we either have clients self-report or self-record, or we even, give, or we do it over the phone, we've got our audit. When we're talking about emotional, because we're going to start really shifting into this emotional recovery as the means of staying away from risky situations that challenge us to make relapse sound like a great idea, right? What is it that is taking place in our client's life where their first thought is, jail sounds fabulous, whatever about losing my kids. All right, school, I can always go back, or just straight out like, I'm done. I don't qualify for this. I'm out of here, right? Like our role, like clinical denial is telling us, is to figure out what that emotional conflict is and resolve it. And guess what? AA doesn't do that. And guess what? We can't do that. So we do need to figure it out though, right from the get-go. Where are we at with this person? The audit, it's only minimal, emotional. The question 7, how often during the last year have you had a feeling of guilt or remorse after drinking? On a scale of never to daily, the DAST, at least it's got 3 questions, right? But this is generally even more geared towards our narcotic afflicted individuals, because we have so many that are like pretty dedicated to alcohol, right? And here we've got like the 3 questions, and that is based around like after drugs and alcohol use, right? Is there your own personal guilt? Do you have family complaints that are going to lead you into, a feeling of guilt because you're being shamed or what have you, or family neglect? So at least there's 3 questions that are closed, yes or no. Does somebody that either is mandatory to getting help for an affliction, or somebody that kind of wants to test the waters to see if they got something going on, but they're in emotional unresolved conflicts, are they really going to say yes, that they're neglecting their family? I'll tell you what, honestly, I wouldn't. If I have no therapeutic relationship with somebody and this is like the first time that I'm meeting them, absolutely not am I going to share my deep, dark secrets. Our DSM-5 criteria for our AUD. I'm just going to gear this real quick to our alcohol use disorder. But we do have recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. I'm just checking the time, folks. So I'm not sure if you guys read anything on the bioethicists do. So Dr. Jenny Blumenthal Barbie and Dr. Peter Ubel, they have a brilliant paper. It's kind of a mouthful for me to say. I had to write it down. So in defense of denial, this is the article, difficulty knowing when beliefs are unrealistic and whether unrealistic beliefs are bad. So their definition on the bio, sorry, I got to move my little camera here. And we are clicking buttons. So their definition, right, is denial occurs when a person has a desire for a certain outcome and fails to think about or face the high probability of the undesired outcome, right? That is what denial is. That's something I can buy into because I fully believe that people are aware, and we're going to get into why I believe that. But so I get behind this. And this is like some of the things that are coming up about trying to figure out about denial and how they came to this conclusion, right, is a couple of major points. The sharp distinctions between hope, right? We're dealing with addictions, but this actually goes, this study and journal article was written on like an entire healthcare field. But very, very relative to addicts and alcoholics, especially those that are in that I need dialysis, I need to go on a liver transplant list. So very relative. So the sharp distinction between hope and states like denial, self-deception, and unrealistic optimism. So there's only a brief part, and that's where I pulled out this whole, their little snippet of denial, is that throughout this article, denial, self-deception, and unrealistic optimism are categorized in one, because all three of those affect hope. All three of those lead into an individual maybe not hosting the level of autonomy that they could have or should have. They also argue that it is difficult to determine whether a patient is really in denial or self-deceived or unrealistically optimistic. And we do have those clients that come in, right? And they are on fire. They are getting sober. They've done this deal before, or they scared themselves enough that their only option, right, that they believe is to get sober. And they're going to do whatever they take. However, what if they're in acute withdrawal? Are they really able to be making these decisions? So where do these conflicts come from? Here we go. Hope, right? Comes from hope. And their definition of hope occurs when a person has a desire for a certain outcome, believes the desired outcome is possible, right? Probability is greater than 0, and engages in certain behaviors related to it, such as praying for it, thinking or fantasizing about it, or even planning for it. Being in our field, like that's a little bit scary to think about. How often are we giving people hope that may not be for them? And that's where this false hope comes into. The false hope, which occurs when a person has a desire for a certain outcome, right? I'm staying sober for ever. How many times do we hear people say, I'm staying sober forever? Or, we have the other people that are like, man, I don't think I can stay sober forever, right? So we have that false hope, which occurs when a person has a desire for a certain outcome, believes it's possible, when in fact it is not possible. And when we are helping clients getting sober, when we're helping clients, fix a broken ankle, we don't know if that ankle is going to be perfect after 6 weeks of a cast. We don't know. We're pretty sure, right? Our probability is far greater than 0. It's probably 90%, right? However, it's not 100%. And that true is for our client, our patient, to look at and think of, what if recovery and maintained recovery over the course of 2 years, because a lot of studies are 2 years, and pretty much like our deferred prosecution is 2 years. So it's very easy to measure that part, take a whole population, hope that they're going to give us the information, and whether they maintain the recovery or whether they don't, we can get that accurate data as long as they do come back. It's always nice when they come back in like year 3 and year 4 and they've been released from whatever circumstance that had forced them and placed them in a position to come see us. Remember too, though, there are a lot of people that end up in front of us that don't belong in our rehabs. They don't belong in our outpatient centers because they aren't afflicted. Sometimes a person does make a bad choice. Sometimes a person does make a couple of bad choices. When we see patients that are 45 years old, or we see clients that are 45 years old, and they have had a couple bumps and bruises along the way, that's pretty normal. Like, there's plenty of times that I cost my parents copays as a kid. It doesn't mean that I'm ungraceful. It doesn't mean that I'm incapable of walking correctly. I am fully functional. I just tripped and broke my ankle, right? So this is going to lead us into these mutual support programs, since we are talking about hope and we are talking about denial and how it's the desired outcome, right, that may or may not be possible. So let's talk about the mutual support programs that we send people to, or we suggest. And I do say that we send people to them because a lot of our programs, our clinics get paid, either we accept federal money or we accept insurance money, and requirements are to do what, 2 to 4 moral support groups. And so we've got Nar-Anon and Al-Anon. Those are for individuals that are affected by alcoholics and addicts. We have Alcoholics Anonymous, Narcotics Anonymous, Marijuana Anonymous, Cocaine Anonymous, Celebrate Recovery, which this is a religious kind of side of a 12-step program, right? And then we have Agnostica, Alcoholics Anonymous. And like I said, everyone will get this presentation, but maybe make a note of that. There are plenty of atheists and agnostics that stay sober. And in Agnostica, Alcoholics Anonymous, they do use the big book, right? The big blue AA book. That's what I'm talking about. They do use that. And everywhere that it says God, they bypass it. Everywhere that it says divine and universe, they bypass it. And that's okay. And guess what? They still stay sober. So that too, when our clients come to us and say, like, I don't believe in God, or this higher power thing is shit, or like, this doesn't exist. Cool. That's totally fine. If you want them to go over to an MSP, send them to Agnostica, Alcoholics Anonymous. I'm just going to like throw this out there real quick while we're on the topic. Something that challenges me with my peers and my colleagues are, it doesn't matter if you're addicted or afflicted or what, right? You don't have to be an alcoholic to be a counselor, and to be a darn good one, right? A really, really effective counselor. You don't need to have this whole former horrible story of a train wreck kind of a thing. You can have a very awesome white picket fence, kind of a life. I heard that from a client. It's the only reason why I say it. So I guess we'll put up some quotes for it. But so here's the deal is, if we are asking our clients or our patients or our friends and family, if we're asking or we're suggesting for them to go to any of these 12-step programs or moral support programs for their moral disease, if we're suggesting that they go to these things and we have not done that ourselves, that's a problem, right? That's kind of like denial. That's sort of like refusing, right? When we're suggesting to people and then we hide behind ethics so that we don't have to tell them, like, I'm an alcoholic, I've never done this, or I have no idea about alcoholism and I've never done this. When we are deliberately allowed to omit that we do not do this or we don't need to do this, but we are suggesting and directing people to there, that's a problem for me. So I'm just going to throw it out there that it doesn't matter if you are addicted or afflicted, if you are a social or a non-drinker or a normal drinker, it should be incredibly easy to not drink and utilize one of these programs in its entirety, exactly as it's laid out. It's important for me and for you to know what our clients are getting themselves into, so that when they come back to us and say, hey, this assignment that you gave me to like write down my first step and go read it to a sponsor and have that sponsor, sign off on it, or maybe 5 other people, like, hey, that's not how this program works, and if we're measuring their completion of this phase based off of that they did what we were told that they were supposed to do, that's a problem. No wonder they're confused. 12-step programs utilize the moral denial concept. 12-step programs kind of use that stages of change, and clinically, if we're going off of APA, that's not how we operate. If we're going off of APA, we're going to do it that psychoanalytic way, the psychodynamic way. But here's the fun fact. This is where the emotional sobriety comes in, and it's open to all. And it's a mutual support program, and it's a 12-step program. And wouldn't you know it, it is geared towards 5 different patterns, but denial is one of them. Let me go ahead and pause that timer. Sorry. So denial is actually one of them, and it is called Codependence Anonymous. Woo woo. And guess what a codependent is? A codependent is just someone that cannot have emotionally healthy and respectful of themselves and other relationships. That's it. It is somebody that that just isn't able to consistently maintain that freedom of self and permission towards self, and freedom and permission for others to do what they need to do. And here are their denial patterns. And again, we've now had 2 definitions of denial. We now understand 6 theories of denial. All of this keeps on coming up unconscious, right? Unconscious awareness for our responses, refusal to acknowledge. Here's what the coded denial patterns are. And this is a fabulous program. It has a workbook, very, very safe outlet. So have difficulty identifying what they are feeling. minimize, alter, or deny how they truly feel. And in that, denying how they truly feel is acknowledging their feeling. It's not refusing to acknowledge it. It's just not going to acknowledge their feeling. Perceive themselves as completely unselfish and dedicated to the well-being of others, right? How many of us are like, I am a selfless human being. I do all of this community service for those that are sponsors. I sponsor people and I host the burden of my patients, and I do my mindfulness, and it's all for the greater good. And I recycle and I compost, and I recycle batteries. I'm a great human being. Lack of empathy for the feelings and needs of others. Label others with negative traits, right? And so some people would think that that is deflection, right? That isn't a word, but so projection, would mean people would say like, oh, that's when you're labeling someone else, or it's somebody else's deal. And per coda, right, that's actually a pattern of denial. So think they can take care of themselves without any help from others. Now, this stems from not relying on another person to help them through life, but this is when they do need help and they don't ask for it because they're doers, right? They will do a lot and then afterwards maybe realize, oh, I said yes when I meant no, but I didn't know how to say no. Mask pain in various ways, such as anger, humor, or isolation. Now, I will tell you, I was told once that I was deflecting when it was actually in school. And we were doing this assignment, right? We were doing this recording thing, and I actually got pretty raw because, as you can see, I'm like very bold and brazen, and I like to have a good time. And so we were talking about this subject, and man, like I just got so much emotion. And up until that point, everybody had just seen me as this like, I was kind of crabby during that time when I was in school. I was exhausted, and I was learning so much about this, and it was so challenging for me to set aside everything that I knew personally and have to look at things clinically. And so I got a little bit raw, and I tried to make a joke about it, and this person was like, oh, you're deflecting. And I remember thinking to myself, I was so angry that this person said that, because I was funny since I could talk and I could walk. I was always making jokes, right? This is long before I understood that the world was cruel. And so my humor wasn't about me deflecting. The issue that I found to be true, because I did choose to work the Codependence Anonymous program straight out. It's beautiful, it's graceful, it's very loving, probably one of the nicer gifts I've ever given to myself. And I continue to work that. I suggest it for everybody, but I absolutely suggest it for us counselors. Because we don't want to get distracted when we're talking. We don't want a writing reflex. It helps to take care of all of that stuff. No labeling traps, right? If we're labeling others with negative traits and codependence, right, then like maybe we're labeling, our clients, and therefore we're the ones in denial. They're not in denial. Do you see this like disgusting roller coaster that we can be on sometimes, and we don't even want to acknowledge that. So I was pretty upset, because what I had found in that is that I wasn't saying thank you, right? Because I wasn't allowing myself to feel those feelings in that moment. I didn't give myself permission to, though I had showed a truth and a rawness and vulnerability on camera when it was brought to my attention, I kind of felt attacked in a way. And, my peers, it kind of was like my peers looked at me like, oh my God, like she's got a tear, she's crying, I mean, it's like, it was a little bit shocking for all of us to see that I was willing to get raw and vulnerable. It was a counseling theories class, so you have to do it, right? And it just feels good when you do. And so, but that was the problem. is that I hadn't fully given myself permission to be raw and vulnerable in front of all of my peers. And at that point, I had been with everybody for, I don't know, 12 or 13 classes, 45 hours of school a week. You become really, really close. But I had only allowed myself to be that way with the one person at the time that I was speaking about, that one circumstance. And so I wasn't deflecting with humor. I was trying to piece together why I couldn't say thank you for sharing with me their shock, right? Like, if this is shocking, or like if whatever I did, whatever the client does or whatever, like emotes a feeling, that is so large and so different, that's a thank you. And not in the Southern thank you way, right? We don't say F you to anyone, or to clients especially. So moving on, expressing negativity or aggression in indirect and passive ways. We've seen this a lot in COVID. If you have been on any social media groups, it's like I've seen plenty of people like rage keyboard and get indirect and get passive, and that's really not who they are. And do not recognize the unavailability of those people to whom they are attracted. And this isn't necessarily like a sexual attraction, right? This can even be like your really, really close friends. This could be, coworkers at work that you really get along with, but not recognizing they're not available for you. And some of that comes from not even asking permission first if the person has time to talk on the phone. So that's a part of being in denial. Now, I'm going to take a sip of water. I hope you guys are doing good. Let me know if I need to slow down. We are so close to being done. So Matrix 3 and the ASAM, right? Our dimension 3. This is where our emotional and cognitive recognition, comes into. Like, there is a very small amount of things that can take place with a person emotionally in dimension 3 to go from a risk 0, like he or she is good to go, right? They got their thing going on, not worried, not concerned, to only a couple little hiccups. The client only says a couple little things, and all of a sudden they're in risk level 1, right? And now we've got this low intensity. We got to start bulking up on therapy. They may say a little bit more. And then what happens when they come into, our risk level 2? And then they definitely need to have individual counseling and group counseling and bulk up on their MSPs and maybe get held back in their phase, and there's these drastic consequences for very, very preventable thoughts, feelings, and actions. So when we have to look at them on their dangerousness or lethality, our interference with addiction efforts, recovery efforts, very, very simple. The fuck-its, very easy to get there in early recovery or in dry recovery. And if we are not constantly doing our risk assessments and just doing our check-ins that are more than just our HIMI check-ins, and like, what do we got going on? Like, if we're not just really getting down into the nitty-gritty and asking and affirming, our clients very much, whatever's going on can affect their social functioning, can affect their ability of self-care. I ask my clients, how many showers were you able to get this week? Because sometimes it's, 4 or 5, and if the answer is 1, there is something going on. There are 7 days in a week. It takes 6 minutes to like do a full scrub down. What was going on so great in that person's life? Great as in a lot, right? How much distraction and noise was taking place that the person only had one time of 6 minutes to themselves. So, and then their course of illness. So change our ask to change our affirmation. Now, since we are totally going over time, and I'm so sorry, but thank you for following through with me. So changing our ask to change our affirmation, what I have done is we're going to take the denial patterns of Codependence Anonymous, and we are going to ask that pattern question. I'm sorry. And then we are going to look at the recovery patterns. There are recovery patterns, and we can utilize those as our affirmations, or if necessary, then we can go ahead and ask. And I'll just try to skip through these really quick. I did put up some slides that will show you. So let's just do a couple of these actually. So are you having difficulty identifying what you're feeling, right? Like, let's just ask them that. And when they say no, it's okay for it to be a closed, it's okay for closed questions. Sometimes we don't need to be pulling so much out. It's okay for yes or no. If you have an affirmation that is suitable to your yes or no question. So in CODA, there's every pattern has a recovery pattern, and it's important to know that. And we do opposite action and mindfulness anyway. So it really takes everything together. Everyone knows who Melody Beattie is at this point, hopefully, or Marianne Williamson, and pretty sure that they were best friends. So are you having difficulty identifying what you're feeling? And when they say no, then it sounds like you're aware of your feelings and identify them. You know the difference between your thoughts and feelings. Taking care of yourself. Are you taking care of yourself without any help from others? Right? This part goes in, again, dimension 3, self-care. This is like, if applicable, right? That's great that you acknowledge sometimes you need help from others. Are you recognizing others' unavailability to you? Again, dimension 3, social functions. When they say no, then you're learning to pursue intimate relationships only with others who you want and are able to engage in healthy and loving relationships with you, right? Like, that's huge. Or if they say, no, I'm not recognizing their unavailability, then we can turn this out. The recovery pattern, let's go ahead and just turn that into a question then, right? Then we would just say like, hey, so are you in this learning about the intimate relationships and who's available to have one, right? Are you learning if it's like a healthy relationship? Does it feel toxic? What's going on with that part? So labeling others with their negative traits, right? Not deflecting. This is denial. And when they say no, right? I'm done with that, then they not only are giving themselves self-care because they are not speaking negatively to themselves so often that it would only be natural and normal for them to label somebody else. And they're also not stereotyping. That's fabulous. We need more of that. So our affirmation, it's great that you acknowledge that you own the negative traits you perceived in others, right? So let me jump through these because I do know, I am so sorry. I do know that we are coming out of time. Okay, feelings wheel. I'll be really quick with this. So the feelings wheel, right? We have sad, joyful, powerful, scared, mad, peaceful. The feelings wheel can be used for absolutely anything. I have a little pocket card. I also have one on my wall. My kid has one, and she's old enough to have this big one. But because people understand that I'm sad, I'm joyful, I'm scared, I'm powerful. But then to expand and enlarge on that, again, these can be provide illicit conversations, right? This can be a safe way for your client to tell you what's going on. This can be them seeing as simple as they feel because they can't really identify anything more: sad, peaceful, mad, scared, powerful, joyful, or they can go even deeper into that and say, you know, if they're sad, right? Are they guilty or ashamed? That's two totally different things, right? We have that guilt and we have that shame. Some comes from what we are thinking about ourselves. Other comes from what others are thinking about us. Or does it go even further than that and even deeper than that? The deeper digging comes from the large full circle side, right? And then it starts coming in. So what if your client straight tells you, hey, Joe, like this week I felt inadequate. You know, this week I felt jumping into mad, right? This week I felt totally hostile, you know, and jumping over into powerful, you know, but it's like I was being appreciated at work. So I don't know why I'm going back to sad, don't know why I felt stupid, you know, so you can utilize this feelings wheel to have your client and even you at home in your personal life or with your colleagues, whichever, to go through your week or your day and just start identifying the feelings. You know, when this happened, I was like this, but it was weird because this had happened. But then I was totally feeling this way. And now you're figuring out the circumstance of it. You're figuring out the actual place or institution, the physical setting. Right now, we're starting to work with our dimension 6. What is our recovery environment looking like? You know, which stems from dimension 3 to get us into our readiness ruler. What if we are our readiness to change? What if we are starting to slip back in denial, right? So feelings wheel. And oops. Lastly, just gonna really quick, this is what the other coda patterns are. So low self-esteem, codependence, right? Have difficulty making decisions. I'll just jump over through a couple of these. In recovery, I trust my ability to make effective decisions, not good decisions, not great decisions, not the right decisions, the effective decisions. Codependence with low self-esteem. Seek recognition and praise to overcome feelings of less than. On the opposite side, when they are recognizing in themselves as being lovable and a valuable person, oh, sorry, my eyes are all weird. Okay, so when they seek their own approval first, right, from themselves, and examine my motivations carefully when I seek approval from others, right? So CODA is teaching somebody already how to look at their motivation, their barrier, their challenges. And when people are working 12-step programs, when they are doing outside MSPs, and then they're coming back to talk to us, if we are not speaking their language, we're challenging their recovery. So when we're not speaking their language, if a person is going to CODA, if we're like, hey, you've got some emotional regulation stuff going on, let's go ahead and have you go check out CODA. If we're not using terms like, oh, I perceive myself, or oh, you perceive yourself this way, which can be the codependent action of addiction, CODA addiction, or it could be recovery pattern. The word perceive is fine to use. It is fine. Okay, compliance patterns. Let's do making decisions without regard to consequences. That's compliance, right? And what do we call it in the addictions field? Right? Exactly. So making decisions without regard to consequences, the fuck it's. Well, generally, I don't think of, you know, walking away from the program or walking out of my meeting or completely breaking group norms, you know, doing these things and thinking that it's with impunity. I don't think of that as being compliant. But you know what? It is. It is a method of compliance. So then you jump over to, I ask my higher power if the client, believes in a higher power at that point. Ask my higher power for guidance and consider possible consequences before I make decisions. Now, do you see how under the compliance pattern and the recovery pattern of compliance, how that relates to Dr. Judy Blumenthal Barbie's definition and Dr. Peter Rubel, their definition of denial, right? The desired outcome, right? What is that, the probability of it looking like that? What's that possibility? All right, control patterns. You guys are going to get this PowerPoint because we definitely are out of time. But let's do, so deflection, right? Being deflecting, in which people think that it is setting aside all of your feelings and blaming somebody else. That's projection, and that's absolutely accurate. And everybody that I asked that got that one right. So using charm and charisma to convince others of their capacity to be caring and compassionate. That sounds super narcissistic, and it is one of the traits, but this isn't a psychoanalytical presentation. So I behave authentically with others, allowing my caring and compassionate qualities to emerge. And again, when you are seeing these things from your clients, if you as the clinician and a counselor get into this emotional program of emotional sobriety and work these emotional steps, it's going to be so much easier to be able to transpose that to your client, to be able to give them a new outlet. So when you are sending them out into these hope-based, right, 12-step moral programs, you're speaking their language, you're doing their deal. When you say that you understand how they're feeling, they are going to know you're not lying. They're going to be able to see it in your eyes. Right? You can't bullshit a bullshitter. So lastly, avoidance patterns. And a lot of people see these avoidance patterns as a sense of denial. Again, it's very important that we look at our choice of words. Let's stop saying somebody is in denial when they aren't meeting these patterns and characteristics, which put them into the emotional conflict or the anxiety because they are fully aware. So let's really be careful about when we're using the term denial. But looking at these avoidance patterns, right? Allow addictions to people, places, and things to distract them from achieving intimacy in our relationships. Suppress their feelings or needs to avoid feeling vulnerable. Pull people toward them, but when other gets close, push them away. That push forward, pull back, cat and mouse. Believe displays of emotion are a sign of weakness. Now, most people wouldn't think, believing that an emotion is a sign of weakness isn't a pattern of avoiding, but it is, right? Because we want to avoid not only being that person, but being like them. You start labeling them. On the opposite side, in this case, believing displays of emotion are a sign of weakness. If a codependent, if somebody is in emotional recovery, if they are maintaining their emotional sobriety, then they will be able to, I honor my authentic emotions and share them when appropriate, right? I had an instructor once tell all of us in class actually, only share your story with those that have earned it. And that was a game changer. That was huge. Because for me, I always felt the need to share. I always wanted that empathy. I always wanted to give that compassion. I thought people needed to hear. They don't. They don't. I need to hear what they've got going on. I need to listen deeply to what they've got going on. I can make them feel comfortable, but I can also hold my story and my emotions to where it's appropriate. And some people, it's not appropriate. So I believe that we are at our last slide. So yeah, so here's our denial pattern. This is like the pretty one, not the one that I typed out. So the denial and the recovery pattern. And now we should be at our last slide. We are, so let's stop sharing. And our wrap up pretty much is just me saying thank you so much for, again, rearranging your schedule. I hope that you had fun. I will go ahead and send this out in a PowerPoint. There is a survey that I'm going to send you to your email. If you can just fill that out. It's totally fine for feedback. Again, I hope that I didn't bruise any feelings or challenge your thoughts as much as I had felt challenged by this as I was learning about it. If I did, I do apologize, and I would like us to kind of talk through that. It's important for me to learn differently, and that is by feedback, and that is by constructive criticism. And I have gained a little bit of thick skin. And if I can't be emotionally vulnerable with all of you, then maybe I can't be emotionally vulnerable with myself too. So again, sorry, I'm just gonna wrap this up really quick, and thank you so much for joining me today. Enjoy the rest of your day. I'm sorry that we went a little bit longer, and I will get the what is deflection presentation set up and ready to go and send you an invite. So thank you again. Take great care.